So when I counsel patients about their prognosis at the time of diagnosis, they have so many questions about, what's the chance of me getting into remission? What's the chance of long-term survival? Am I going to need a transplant? And all of these questions are in their head, and I have no answers for them at the time of diagnosis. All I can say is it's important to start a treatment that gets you in remission. And there are certain markers that we use to choose a therapy that we think will improve outcomes. FLT3-ITD, intensive chemotherapy with quizartinib or midostaurin. Core binding factor leukemias, maybe the addition of gemtuzumab ozogamicin to intensive chemotherapy. But for the most part, at that initial diagnosis, we still do not know the answer as to whether in unselected patients, if intensive chemotherapy or less intensive chemotherapy is important. We only know that these cytogenetic features and mutational profiles are important in long-term prognosis. So how do they help? Well, once you get that data back, it's become pretty clear that for patients with favorable risk disease, according to ELN 2022 and NCCN, which includes core binding factor leukemias, 821 and version 16, NPM1 mutated without a FLT3-ITD mutation, and CEBP BZIP mutations. In that group of patients, I think there's enough clinical data to show that outcomes are very good with intensive chemotherapy, and in patients who achieve deep remissions, although they can still relapse, there does not seem to be a survival benefit by transplant in first remission. And the reason for that is when they do relapse, if they relapse, they can get into a second remission quite frequently and then go on to the transplant. So a number of studies now showing for favorable risk disease, transplant may not be necessary if you get them into a deep remission. On the other hand, for adverse karyotype and adverse mutational analysis, so chromosome 5 and 7, complex karyotypes, chromatin modifiers, like ASXL1, TP53, chromatin, and spliceosome mutations. For those patients, there's data that those patients do benefit from transplant. And in fact, when you think about, how about if I get a patient into a really deep remission and it's MRD negative, but we know by the risk stratification they have poor risk disease, some of the clinical data that's coming out now and has been presented and reviewed today in our MRD session suggests that those patients, even if they're in a deep remission, should undergo allogeneic transplant based on their initial risk stratification. And then the group of patients that we can debate are the intermediate risk patients, a great grab bag of different cytogenetic and mutational profiles that hopefully over time will have more specific interventions for them. But to answer your question, still this risk stratification based on cytogenetics and mutational analysis is used every day by clinicians to help guide their patients in making decisions about potentially curative approaches to their therapy with or without allogeneic transplant.